Hello and welcome. My name is Dr. Pascal and this is another video from JetMouth on cardiovascular system examination. Cardiovascular system examination, just like every other system examination, is used to elicit signs of diseases relating to the cardiovascular system. And in this video, we'll be dividing it into the theory part, the step-by-step examination of the cardiovascular system, and then the OSCE guide. Generally, cardiovascular system examination is divided into the following. 1 is where you check for the peripheral pulses. 2 is where you check the blood pressure. 3 is where you check the jugular venous pressure. 4 is where you examine the precordium. The 5th one is where you check for extensions to the lungs, to the abdomen, and to the lower limbs. So in this video, we're going to follow these 5 steps. Bear in mind that in most of your examination, you may not be asked to do the complete cardiovascular system examination, and that's why we had to split it into these 5 groups. So most times you're either asked to examine for peripheral pulses, or you're asked to examine the precordium or check the blood pressure. So you may not be asked to do the whole cardiovascular system examination. Just keep that in mind for exam purposes. So just like in other of our videos, we divide it into the pre-examination phase, the examination phase, and the post-exam. So in the pre-exam, this is where you greet your patient, introduce yourself, explain the procedure to the patient, you obtain an informed consent, properly position your patient in cardiac position, that's at angle 45 degrees. Then you expose your patient properly, exposing the chest area. Then you ask for a screen and a chaperone. So in the examination proper, we are going to be talking about the peripheral pulses. We check the blood pressure. Then we also talk about the jugular venous pressure measurement. Then we now examine the precordium and then talk about other extensions that are related to the cardiovascular system exam. So for the peripheral pulses, you ensure the patient is properly positioned in cardiac position. Then you examine with 3 fingers. We usually don't use 1 finger, so try to use 3 fingers. So for the peripheral pulses, while patient is lying in cardiac position, you examine the 2 sides. So as you're doing on the left side, you also do on the right side. So in some cases, the pulse might be absent on one side, especially in Takayasu arthritis or congenital vessel malformation. So you also use 3 fingers, not 1, to palpate for the pulse. Ensure you palpate at the correct anatomical position. So while palpating for the pulse, you look out for the rate, you look out for the reading. You also look out for the pulse volume. Then you check for the radio-radial synchrony. You also check for the radio-femoral delay. Then you check for the thickness of the arterial wall. So the normal rate for adults is between 60 to 100 beats per minute. So if you have a beat more than 100, that's called tachycardia. Then anyone below 60, that's bradycardia. So apart from the rate, you also look at the reading. Is it regular or irregular? Most normal pulse will be regular. But if you get irregular, then we classify it into regularly irregular and irregularly irregular. For irregularly irregular, we have atrial fibrillation, which is the commonest. Then for regularly irregular, we have atrial flutter with a fixed block. Then the next one we are going to talk about is the volume. You can have a small volume pulse, full volume pulse, or a large volume pulse. So for small volume or low volume pulse, it is commonly seen in aortic stenosis, in shock, heart failure, or even in severe dehydration. Then for full volume pulse, this is usually normal in most individuals, or a mild exercise, or anxiety, or fever. Then we have large volume pulse. This is commonly seen in aortic regurgitation or severe anemia, or even hyperthyroidism or pregnancy. Then after the pulse volume, you move over to checking for radio-radial synchrony. You might have a unilateral pulse, which can be seen in Takayasu, just like we already mentioned, or radial artery stenosis. So it's always good to compare the 2 sides. That's the essence of the radio-radial synchrony. Then apart from that, you also check for radio-femoral delay. This is commonly seen in coarctation of the aorta, where the femoral pulse is slower than the radial pulse. Then we'll look at collapsing pulse. If there is a wide pulse pressure, that's a systolic and diastolic difference of more than 50 millimeters of mercury, often seen in aortic regurgitation. Then if you perform test for collapsing pulse, then the pulse disappears on raising the upper limb above the head. We'll also perform it during the step-by-step examination. Then after that, we'll look at the thickening of the arterial wall or arterial wall thickening. Then we have a typical examination we do, that is for Locomotor Brachialis, is also part of the peripheral pulse assessment. While assessing peripheral pulses, examine the brachial artery for Locomotor Brachialis. If the arterial wall is thickened or the pulse appears pounding or collapsing, this is a visible or palpable pulsation in the upper arm. This usually suggests a hyperdynamic circulation often seen in aortic regurgitation. Okay, so you palpate the brachial artery along its course in the upper arm at the medial side, just above the elbow crease. Observe for pulsatile movements or visible arterial contraction with each heartbeat. So you compare both arms for symmetry. So the clinical significance of this is that it can indicate aortic regurgitation or any other hyperdynamic state. So other pulses that we'll check out for, you check out for brachial pulse, check out for carotid pulse. You check on the two sides, but you do it one at a time. Then you check for superficial temporal pulse, check for femoral pulse, you check for popliteal pulse, you flex the knee and check. Then you also check for the posterior tibial pulse, and then lastly we'll check for Dorsalis pedis pulse. So for your commentary for under pulse, you can say pulse rate is 72 beats per minute, full volume, regular, atrial wall is not thickened. There is radio-radial synchrony, but no radio-femoral delay. Pulse is not collapsing. All other pulses are present and normal. That's just a simple commentary under the pulse. Then we go over to blood pressure. We use a sphygmomanometer to check for our blood pressure. So we have two ways where you can check your blood pressure. You can use the palpation method or the auscultatory method. In the palpatory method, you apply the cuff 4 cm above the elbow. Then you palpate for the radial pulse and then inflate until you are not able to hear the radial pulse again. So you can inflate maybe 20 millimeter mercury above the point where you stopped hearing the radial pulse. That is the palpation method. Then for the auscultatory method, you place the diaphragm of your stethoscope at the elbow. So you auscultate for brachial pulsation. So you gently deflate your sphygm. While you're deflecting, you're going to hear the first sound, which is the systolic blood pressure. Then at the point where you stop hearing that sound is your diastolic blood pressure. So for a normal blood pressure in adults, usually between 110 to 120 millimeters of mercury, while the diastolic is between 70 to 79 millimeters of mercury. But if the blood pressure is between 120 to 139, that is for systolic, and a diastolic of 80 to 89, then we'll call it elevated blood pressure. Okay, so for grade 1 hypertension, the systolic blood pressure is between 140 to 159 millimeters of mercury, while the diastolic blood pressure is between 90 to 99. Then for grade 2 hypertension or moderate hypertension, the systolic blood pressure is between 160 to 179 millimeters of mercury, while the diastolic blood pressure is between 100 to 109 millimeters of mercury. Then the third aspect, which is the severe hypertension or the grade 3 hypertension. Here, the systolic blood pressure is equal to or greater than 180 millimeters of mercury, while the diastolic blood pressure is greater than or equal to 110 millimeters of mercury. Then we also have what we call hypertensive crisis. So in hypertensive crisis, divided into two. We have hypertensive urgency and hypertensive emergency. So the two of them, they have a BP of equal to or greater than 180 over 110. So for hypertensive urgency, the BP is equal to or greater than 180 over 110. But the difference here is that in hypertensive urgency, there is no acute organ damage. But in hypertensive emergency, there is acute organ damage. Acute organ damage such as encephalopathy, stroke, acute heart failure, aortic dissection, or acute kidney injury. In a patient with that level of hypertension, you elicit this end organ damage or target organ damage, then you'll be able to differentiate between hypertensive urgency and hypertensive emergency. Then the next aspect is checking for the jugular venous pressure. So for jugular venous pressure, you ensure the patient is well positioned in cardiac position. the head should be turned slightly away to the side you are examining. So if you're examining on the right, the patient should turn the neck towards the left. So you first of all identify the jugular vein. So you look between the heads of the sternocleidomastoid muscle. We usually prefer the internal jugular because it usually gives us a more accurate measurement than the external jugular. Then note that the jugular venous pores are not palpable, unlike for carotid pores. Carotid pores, you can actually palpate, but for jugular vein, once you palpate, because it's a vein, once you palpate, the pores disappears. Then another thing that can differentiate the two of them is that jugular venous pulsation is biphasic or multiphasic, in the sense that if you're looking at it, it's looking like it's beating 2 times or more than 2 times. But for carotid pulse is just one wave up, unlike in jugular vein. So another thing that will differentiate the both of them is respiration. Inspiration and expiration affects jugular venous pulsation, but it does not affect the carotid pulsation. Another thing that will also differentiate the two of them is that carotid pulsation is not affected by patient posture or position. So even if you ask the patient to sit up or change position, the carotid pulsation will remain. But jugular venous pressure is affected by change of posture or change of position. Then for measuring your jugular venous pressure, you identify the highest point of venous pulsation. Then you place a ruler vertically at the sternal angle. So you locate the sternal angle, also called the angle of fluid. So when you locate it, you place a meter rule vertically at that point. Then you measure the vertical distance between the highest point of the venous pulsation and the sternal angle. That will give you the JVP. And the normal JVP is between 0 to 4 centimeters. So if you have something above, then you have a raised JVP. So when it comes to the jugular venous pressure, there are certain maneuvers you can actually do. The commonest one we do is the Hepatojugular Reflux. Here you apply pressure over the right hypochondrium. You apply this pressure for 5 seconds or up to 10 seconds. Then you observe the JVP. So there should be a sustained rise of the jugular venous pressure just by mere inspection. So by so doing, the hepatojugular reflux will be positive. So that's one of the maneuvers we do for jugular venous pressure. And when this maneuver is positive, it usually suggests a right heart failure. Then another important part now is examination of the precordium. Just like I already classified, so we are examining the precordium now. So you observe the chest for any deformity, for any scar. So some common scars you can find a midline scar at the sternum, which might suggest a previous open heart surgery. Then you can also find an infraclavicular aerial scar. This is when you apply a pacemaker or implantation, ICD implantation. So among other scars you can elicit for, you can also see a lateral chest wall scar, which might indicate thoracostomy. So after inspection of the precordium, the next thing we'll do is palpation. And the first place you palpate for is for the apex beat. The angle of Louis or the manubrosternal angle corresponds to the second rib. So below it, you find the second intercostal space and so on. So you move laterally and downwards until you get to where you were able to elicit or palpate for the apex beat. We'll actually show you that during the step-by-step examination. But there's a catch. If you are not able to elicit for the apex beat, you can actually tell your patient to turn to the left lateral position. In that way, it pushes the heart towards the palpating hand. Then if you're still not able to elicit for the apex beat, even while the patient has turned to the left lateral position, you can ask the patient to just do a moderate exercise while lying down, like raising the leg up and down, so that you see if you'll be able to elicit the apex beat. But if you're not able to elicit the apex beat still, you might have to check on the right for dextrocardia. Then we have common causes of impalpable apex beat, such as obesity, when you have pericardial effusion or left-sided pleural effusion. Then it can also happen when there is a thickened chest wall. So in these cases, you might not be able to elicit the apex beat. Then the next thing we'll look out for is for trill. You check for trill by palpating the 4 auscultatory sites. So you palpate and check if you will be able to elicit a trill. Trill is a palpable murmur. We'll also show you that when we go over to the step-by-step examination. Okay, after the palpation, we don't ordinarily percuss in cardiovascular system examination. So the next thing you do is to auscultate. And during auscultation, there are three things we auscultate for. One, you auscultate for the heart sounds, the S1, S2, and possibly S3 and S4 in abnormalities. Then you also check for murmur, that's other added sound. The other thing we also check for is for trills. So for the heart sound, you're expected to hear the first and the second heart sound. And the first heart sound is usually heard when there is closure of the mitral and the tricuspid valve, which marks the start of a ventricular systole. And this usually coincides with the carotid pulse. So to be able to elicit which one is the first heart sound, you palpate the carotid pulse while you're auscultating. You are expected to hear the first heart sound coinciding with the carotid pulsation. So for the second heart sound, it happens when there is the closure of aortic and pulmonary valve, which marks the end of systole and the start of diastole. Then we also have the third heart sound. This is usually due to a rapid passive filling of the ventricles during early diastole. And this is usually heard when you have a dilated cardiomyopathy. Then the fourth heart sound is usually due to atrial contraction, forcing blood into a stiff or a hypertrophied ventricle. This is usually heard in left ventricular hypertrophy due to long-standing hypertension. Then an important thing to note while auscultating is that we have 4 auscultatory sites, and you can use an acronym: all police take money, where A represents aortic area, P represents the pulmonary area, then T represents tricuspid area, and lastly M represents the mitral area, which is the apex beat. So the aortic area is the second right intercostal space, while the pulmonary area is the second left intercostal space. Then the tricuspid area is the fourth left intercostal space at the sternal border. Then the mitral area is the apex, which is usually at the fifth left intercostal space, mid-clavicular line. So apart from the heart sounds, I already told you that you also elicit for murmur. So we have systolic and diastolic murmurs. So any murmur you hear between the first heart sound and the second heart sound is usually a systolic murmur. But anyone between the second heart sound and the first heart sound is usually a diastolic murmur. Okay, we can classify murmur into different grades based on intensity. So we have what we call a Levine scale classification or grading of murmur based on intensity. So we have grade 1. Here you hear a very faint murmur, which is usually heard by an expert. Grade 2 is louder and can be heard by even a non-expert or even in a noisy area. Then grade 3 is easily audible. It's very audible, but there is no trill. But grade 4 is very loud, but there is trill. Trill is a palpable murmur. So grade 5 is very loud, and you can hear the murmur even with your stethoscope barely touching the precordium. And also there is a trill. Then lastly, we have grade 6, which is extremely loud. You hear it without the stethoscope at all, and there is a trill. Okay, here is a sample of your commentary under examination of the precordium. You can say that there are no scars, that the chest is either hyperactive or normoactive. Then there is no trill, there is no apical hive. Then you can also say that the apex beat is palpable and located at the left fifth intercostal space, mid-clavicular line. Then that the first and the second heart sound is present and normal, no murmur. Something as simple as that. Okay, for the murmur, there are some special maneuver we do. So when you hear a left-sided murmur, that's a mitral or aortic murmur, you can tell the patient to inspire and expire. So usually accentuated on inspiration and it radiates to the axilla. But when you hear a right-sided murmur, usually a tricuspid or pulmonary murmur. So after auscultating for the heart sound, the murmur, and the trills, the next thing you auscultate for is for the carotid artery. And we usually do it one side at a time. So you can ask the patient to hold their breath, listen on the left and you listen on the right. Then the other extensions which I mentioned about, such as the lungs. So in the lung, you listen at the basis for fine crackles. This might suggest a pulmonary edema, which presents as fine crackles, and this suggests heart failure. Then you also palpate the abdomen. You palpate for hepatomegaly, which might suggest venous congestion. During palpation, you might find a soft, tender liver. Then you can also check for ascites. Then another extension we look at is the legs. Here we check for, you inspect for edema. Then you press over the medial malleolus for about 5 seconds, whether it's beating or not beating. Then after that, we'll now go over to the last aspect, which is the post-exam. Here you thank your patient, you help the patient dress up, then you perform your high hygiene, and then summarize your findings. Thank you. Welcome to the aspect of this video where I'll be taking you through the step-by-step cardiovascular system examination. And just like I mentioned in the theory aspect, we are going to be dividing this examination into 1, checking for peripheral pulses, then 2, checking for the blood pressure, 3, we'll check for the jugular venous pressure, then the 4th one is going to be where we'll examine the precordium, then lastly is where we'll check for extensions, other organ involvement in cardiovascular system examination. So just like other exam, we are going to divide it into 3 phases. That's the pre-exam, the exam proper, and the post-exam. So let's begin. Good afternoon, sir.
Good afternoon.
My name is Dr. Pascal, and I'm here to carry out cardiovascular system examination on you, which might involve me touching some parts of your body, especially your chest area. Can I go ahead? Thank you, sir. I'll properly expose my patient, exposing the chest wall, and then I'll position my patient in cardiac position, that's at angle 45 degrees, just like this. Okay, after positioning the patient, I will ask for a screen and a chaperone. This is usually for females when examining females. So we ask for screen and chaperone, and then I'll wash my hand and commence. So in the exam properly, so the first thing we check is for the pulse rate, and we use the radial pulse to check that. And while checking for the pulse rate, you look out for the rate, that's the pulse rate. You look out for the rhythm, whether it's regular or irregular. Then you look out for the volume of the pulse, whether it's full volume, normal volume, or large volume. Then you also look at the character of the pulse, whether you have a collapsing pulse or a pounding pulse. Then you also look at if there is any thickening. That one, we usually use the Locomotor Brachialis to check for thickening of the arterial wall. So let's begin. So after checking for the pulse rate and characterizing it, then you check for radio-radial synchrony. And so not to back your patient. So after checking for radio-radial synchrony, you check for radio-femoral delay by palpating for the femoral artery. And we're expected to hear them at the same time. But if there's any delay, that means it's an indication of a possible coarctation of the aorta. Then after that, we'll move over to checking for the brachial pulse. The brachial pulse is on the medial aspect of the elbow, just slightly above the elbow crease. So you palpate, can use 2 fingers or 3 fingers and palpate. So after palpating for the brachial pulse, you look to see if there is any tortuous artery. That's representing the locomotor brachialis. So when you look, this is usually an indication of a long-standing hypertension or atherosclerosis. So when you look, you're expected to see a tortuous artery, but in this case, there is none, so you won't appreciate it much here. So after checking for, then you also check on the other side. So everything you do on this side, try to do it on that other side. So you also look on this aspect. So even while checking for your brachial artery, you are supposed to palpate the 2 of them. So after that, we'll move over to the carotid pulsation. So you palpate for the carotid artery. But when you're checking for the carotid artery, that's the only artery you check one at a time. So you don't have to check the 2 of them at a time, so that you won't cut short the blood supply to the brain. So you palpate for one side, then you palpate for the other side. Sorry, sir. Can you look to the other side? It's on the medial aspect of the sternocleidomastoid muscle. You can palpate that. Then you palpate on this side. And then so not to apply so much pressure, so that you won't stimulate the parasympathetic response. Then after that, the next pulse we'll check for is the superficial temporal artery pulse. Then after that, you come down to the femoral pulse, that's the lower limb. You palpate the 2 of them. Good. After that, you check for the popliteal artery. Here, you tell the patient to flex the knee while checking for the popliteal artery pulse. So after that, the next pulse we check for is the posterior tibial artery pulse and the dorsalis pedis artery pulse. So after checking for the popliteal artery pulse, you check for the posterior tibial artery pulse. This is behind the medial malleolus. So you just palpate behind the medial malleolus. So after that, you check for the dorsalis pedis. So that's that for the peripheral pulses. The next thing we are going to do is to check for the blood pressure, and we're going to be using an aneroid sphygmomanometer. So the first thing you do is to locate your brachial artery. So, and if you look at this curve, you're going to see the artery pointing downward. So we can use either the left hand or the right hand, but ensure to make sure that the arm is at the same level with the heart. So we place the cuff 2 finger breadths above the elbow and ensure that this arrow is pointing downwards in the direction of the artery. We have two methods, the palpatory method and the auscultatory method. So in the palpatory method, you palpate for the radial pulse and you inflate this curve until you are not able to feel the brachial pulse again. So let's inflate. So currently it's at 120. I'm not able to feel the radial pulse again. So, but in the auscultatory method, we assume that this 120 is the estimated systolic blood pressure. So we are going to inflate 20 to 30 millimeters of mercury above this point. So we are going to inflate now and go ahead with the auscultatory method. So I'm going to inflate to 150. Then I'll now use the stethoscope. Ensure the earpiece pointing forward. So you locate the brachial artery. The brachial artery is on the medial aspect of the elbow. So you gently deflate. The points where you start hearing the sound again, that's the systolic blood pressure. Then the points where you stop hearing any sound, that's your diastolic blood pressure. So let's deflate. You deflate gently. So the blood pressure in this patient is 120/80. So that's that for checking for blood pressure. So after checking the blood pressure, the next thing we'll do is to check for the jugular venous pressure. And in this patient, you may not be able to appreciate it because he has a normal jugular venous pressure. But for the purpose of this examination, I'm going to show you how to perform the jugular venous pressure measurements. So you tell your patient to look in the other direction if you want to check on the right. So as you want to check on the right, you tell the person to look towards the left hand side. So please look towards that angle. So you're expected to see a multiphasic or biphasic pulsation of the jugular vein. So we usually use the internal jugular vein. The internal jugular vein is between the two heads of the sternocleidomastoid muscle around here. So you're expected to see the vein pulsating. In the theory aspect, I was able to differentiate between the carotid pulsation and the jugular vein pulsation. So in the jugular vein pulsation, you're expected to hear a multiphasic or biphasic. It's not going to be a one-phase pulsation like this. It's going to be like this. So that's what you're expected to see. So the highest point where you see that pulsation, that's where you're going to measure. Then you locate the sternal angle, that's the angle of Louis, by palpating from the sternal notch downwards. So here is the sternal angle. So here you place the meter rule from 0 points. We measure in centimeter. So you place the meter rule at the points where you have the sternal angle. So then the second meter rule is going to be at the points where you have the highest pulsation of the jugular vein. So if you're able to feel the highest pulsation of the jugular vein around here, then you place it perpendicular to the ruler at the sternal angle, the angle of Louis. So in this way, you're able to check the points where both of them intersect on the centimeter aspect. So for this patient, the jugular vein, there is no pulsation. We cannot even feel the jugular vein. So he does not have an increased jugular vein. And the normal jugular venous pressure is between 0 to 4 centimeter. And in this patient, even if you measure with just the superficial aspect where we are seeing, it's not even up to 1 cm. So that's that for checking for jugular venous pressure. The next aspect of this exam is examination of the precordium. And just like I mentioned, you have inspection, you have palpation, and you have auscultation. There is no percussion in the cardiovascular system exam. So let's move on. You look over the chest, checking for hyperactivity of the chest. You look if you see any scar, which might be a follow-up from a previous surgery, such as chest tube thoracostomy or open chest surgery. So if you look, there is no scar, the precordium is normoactive. So after inspection, the next thing you do is to palpate. So in palpation, the first place we usually start is the apex beat. So we expect the apex beat to be at the left fifth intercostal space, mid-clavicular line. So you palpate using your palm. You can start from here and move laterally, or you can start laterally and move medially. So for this patient, I'm able to feel the apex beat around here. So after locating the apex beat, the next thing you do is locate the angle of Louis. So when you locate the angle of Louis is here, moving left laterally to it, you find the second rib. So downwards, you find the second intercostal space. Then moving downwards again, you find the third intercostal space. Moving downward again, you find the fourth intercostal space. Then moving downward again, you find the fifth intercostal space. So if you look at where my finger is, you see that it is at the fifth intercostal space, mid-clavicular line. So for this patient, it is normal. But if you're not able to feel the apex beat, you can do some maneuver, like telling the patient to move to the left, just turn, so that the heart will be hitting on the palm. So this is one of the maneuver we do. But if you are not still able to feel it, you can tell the patient to do exercise by raising the leg at intervals, just something to excite the heart. So after that, if you are not still able to feel the apex beat, you should not be worried. In most individuals, you may not be able to feel the heartbeat. And I also mentioned cases where the heartbeat may not be felt, such as in obesity, thickened chest wall, and so on and so forth. But in some patients, you might have to check on the right, because some patients that have dextrocardia, the heart might be on the right. So that's another thing to always look out for. So for this patient, the apex beat is at the fifth intercostal space, mid-clavicular line. After checking for the apex beat, the next thing we'll check for is for the apical hive. The apical hive, we use the eminences of the palm to check for apical hive. So after checking for the apical hive, which is an indication of left ventricular hypertrophy, you go over to the parasternal hive. The parasternal hive is an indication of right ventricular hypertrophy, but this patient, there is no apical hive. So the next thing we'll check for is for trios. So we have 4 chest areas or 4 valvular areas. So in these areas, that's where we always check for. We have aortic, pulmonary, tricuspid, and mitral. So the aortic is at the right second intercostal space, while the pulmonary is on the left second intercostal space. Then we have the tricuspid, which is at the left fourth intercostal space. And last, we have the mitral, which is at the apex area, which is the fifth intercostal space, mid-clavicular line. So I always like to start with the apex. So everything we are going to do, we are going to be starting with the apex, and then we'll move ahead. For the trios, we use our fingers to palpate for any trio. Trio is a palpable murmur. So we'll still check for murmur when we get to this auscultatory aspect. So you use your hand to check if this murmur can be palpated. If you're able to palpate any murmur, that means it is a trio. So you palpate the apex, you palpate for the tricuspid area, palpate for the pulmonary area, and then palpate at the aortic area. Then the next thing after checking for this is to auscultate. So in auscultation, we are still going to follow the same sequence. So in the auscultation, we are looking out for 1, the heart sound, the first and the second heart sound, which is normal. or the third and the fourth heart sound. And I already explained the situation where you see the third and the fourth heart sound in the theory aspect. So you're auscultating for the heart sound and you're auscultating for murmur or any other added sound. Then after that, you move over to the tricuspid area. Then we'll move to the pulmonary area and then the aortic area. So after checking for the heart sound, you also listen for murmur. There are some pro tips in certain conditions and some maneuvers that we also do. So in a patient with mitral stenosis, you listen with the bell of the diaphragm and then tell the patient to turn to the left. Sir, please turn to the left. Okay, good. Thank you. Sit back. Then for mitral regurgitation, it usually radiates to the axilla. So when you auscultate and you hear the murmur, you auscultate to the axilla because the murmur of mitral regurgitation radiates to the axilla. So for the murmur of aortic regurgitation, it radiates to the carotid artery. After auscultating for the aortic area, you auscultate the carotid artery. So if the murmur radiates to the carotid artery, that means it's an indication of a possible aortic regurgitation. So after checking for the heart sound and the murmur, the next auscultation that we'll do is to auscultate for the carotid artery. So after that, the next thing we'll do after examination of the precordium is to check for extension, because the disease of the cardiovascular system involves some other organs. So we'll examine those organs to check if the disease has extended to those areas. And one of the organs that we'll check for is the lungs. So you auscultate at the base of the lungs. Sir, please, can you sit up? So you auscultate at the base of the lungs for possible pulmonary edema. You pay attention to fine crackles, which might indicate pulmonary edema in the patient. So after that, the next thing we'll do is to palpate the abdomen. Lie down. So we are palpating for hepatomegaly. So in cases of hepatomegaly caused by heart failure, you're expected to have a tender, soft, and enlarged liver. So you palpate to see if the liver is enlarged. And from our examination, you know that you examine from the right iliac fossa and palpate upwards. So if you're able to feel the liver, that's another indication of a possible extension to the liver. So after that, the next thing we'll check for is for leg edema. So we'll check for leg edema. So you check for pitting pedal edema. You palpate the bony prominence, that's the medial malleolus, palpate and rub it off. So if the swelling continued upwards, you can still go ahead to palpate until the extent where the edema stops. So if the edema extends beyond the knee up to the waist, you have to check for sacral edema. That is that for cardiovascular system examination. So after the examination, we'll go to the post-exam, which is where we thank our patients. Thank you so much, sir, for allowing me to examine you. I'll perform my hand hygiene. Thank you. So in this aspect of the exam, we are going to perform the 3 minutes OSCE guide. Here, we are going to try to be as fast as possible. The same way it's going to be in your exams. Thank you. Good afternoon, sir. Good afternoon. My name is Dr. Pascal, and I'm here to examine your chest, which might involve me touching some parts of your body. Can I go ahead, sir? Okay. Thank you, sir. So I would like to expose my patient's chest and position the patient at 45 degrees. So, and I'll also ask for screen and for chaperone. Then I'll wash my hands. I'm checking for the pulse rate. After that, I'll also characterize the pulse, the rate, the rhythm, the volume, and if there's any thickness. So after that, I'll do radio-radial synchrony. Ensure not to back your patient. Then after that, I'll do radio-femoral, check for radio-femoral delay. Then after that, I'll check for the brachial artery pulsation. Then after that, I'll look for Locomotor brachialis if there's any tortuous artery, and there is none. And after that, I'll palpate for the carotid artery. I'll do it one at a time. Then we'll check for the superficial temporal artery pulsation. Then after that, we'll now move out to the femoral artery. Then we'll check for popliteal. Here, you ask the patient to flex the leg. And after that, we'll check for the posterior tibial artery pulsation. Then the Dorsalis pedis artery pulsation. Then the next thing is to check for the patient blood pressure. Then I will inflate 20 or 30 millimeters of mercury above the point where I got the estimated systolic. Then I'll gently deflate. Okay. Then after checking the blood pressure, the next thing is we are going to check for is the jugular venous pressure. Here, you ask the patient to turn to the other side. So if you are checking on the right, you ask the patient to turn to the right. Then you locate the highest points of pulsation of the jugular vein. So after locating that, you also locate for the sternal angle. Then you palpate from the sternal notch to the angle of Louis. Then you place your vertical ruler from 0 cm at the sternal angle. Then after locating the jugular vein, you place it at the highest point of the pulsation. Then place it perpendicular to the ruler at the sternal angle. Once you're able to do that, you locate the point where it is matching, and then you read off your jugular venous pressure. Next thing we are going to examine is the precordium. And in the precordium, we examine with using inspection, palpation, and auscultation. There is no percussion. So let's inspect. Then you check for the apex beat. Then you palpate for the sternal angle. Go laterally to the second rib. Below it is the second intercostal space. Locate the third intercostal space, then the fourth intercostal space, and then the fifth intercostal space, mid-clavicular line. So after palpating for the apex beat, the next thing we'll check for is for hives. Use the eminences and check for the apical hive. Then you check for parasternal hive. Then after that, you palpate for trios in the 4 valvular areas. Then we'll now auscultate. So while auscultating, keep in mind for heart sound and murmur. So after that, we'll go over to the extensions. Sir, please, can you sit up? So we'll palpate the base of the lungs for fine crepitation, indicating pulmonary edema. Then after that, we'll palpate for hepatomegaly. So you palpate and rub until you are not able to feel the edema again. So that's that. So after that, we'll thank our patients. Thank you so much, sir.
You're welcome.
Thank you.